Okay, good evening, everybody, and welcome back to our webinar series. As many of you may know who are joining us tonight, we are gathered together to talk about issues that are relevant for gynecologic cancer survivors and their family and friends and caregivers and everyone who sort of supports them in their journey. And tonight we are sort of starting the new year afresh. I think all of us make New Year's resolutions, we make plans, we're going to get healthy, we're going to get well. And then certainly I know about January 15th rolls around and maybe my plans weren't going quite as I wanted. And so we're going to take sort of February 1st, a new month. I know it's the 2nd. Don't worry, I'm not disoriented to time. We're going to take February 2nd, aka February 1st, the new month in our year, to sort of regroup and go back to some basics and talk about what is a cancer survivor, what is wellness, and what are some opportunities for cancer survivors to engage in, promote, and advocate for their own wellness as they're developing, sort of as we called this session, sort of setting your course, establishing a survivorship wellness plan. So I'm very pleased tonight that we have Dr. Choi, who's the director of the Primary Care for Cancer Survivors program here at Johns Hopkins, and Steve Bonwit, who is a nurse and personal trainer and physical therapy assistant here in the Baltimore area. And they are going to help us kind of talk about opportunities that each of us can draw on or can use or can seek out to improve upon our wellness in the new year. And particularly for those who are going through cancer treatment or finishing up cancer treatment, really geared towards talking about folks who are cancer survivors and issues unique to them. So I'm going to pause talking. Everybody knows I could talk endlessly. The promises I make before we start is we will finish on time. So we'll be on for no more than 1 hour. And every time there's always more to say at the end. But I will try to limit what I say. So Steve, why don't you go first and introduce yourself? Tell us a little bit about yourself. And if you feel up for it, maybe a fun fact that's not a resume fact, but just an interesting thing about you, a life resume fact.
All right, that sounds good. Well, my name is Steve, and I've been a bit of an occupational gypsy. I started out working in a fitness facility, and then I went to school for physical therapy assisting. Then I became a nurse and worked on the cardiac floor. And so it's been great for me because it all kinds of came together as far as exercise and working with people who might have a medical background. And my fun fact is I am owned by a little Shih Tzu who takes me for walks a couple times a day. So he's part of my exercise program.
That's great. Dr. Choi, do you want to introduce yourself? I gave a title, but introduce yourself, not just the title.
Thank you. So I'm Youngji Choi. It's such a pleasure to be here. I am a primary care doctor out at Green Spring, and I've been at Johns Hopkins for about 5 or 6 years. Grew up in Ohio, did a lot of my schooling in St. Louis before we moved out here, which is the area that my husband grew up in, right outside of DC. We have 3 kids. Who take up a lot of my time in a wonderful way, especially with the snow days we had the last 2 days. Fun fact about me, as a hobby, I do play the flute. I started playing around 5th grade, and I've more or less been able to keep it up. It's been more challenging during the pandemic, but it's nice to have something that's your own special thing outside of work and family. And so that's been mine.
Those are both great facts, and both related to wellness in their individual ways. So it's wonderful. So let's just start with some very broad terms and concepts. And it's interesting. We've done all of these webinars, which I think now this is number 7. And it's got to be more than that, 8 or 9. In none of them have we defined cancer survivor, I don't think. And when I was prepping for tonight, I sort of realized that. So Dr. Choi, how do you define a cancer survivor?
So I've seen a lot of definitions. I think there's sometimes the academic definitions, but one that I have seen that I like the most is that, being a cancer survivor starts at the time of cancer diagnosis, then kind of goes onward through treatment and beyond, even after finishing treatment, I think is the traditional term we use for cancer survivor, but I really like thinking of that term for when you get diagnosed onward. The other thing that I've heard with cancer, defining cancer survivors, is that it not only involves the person who is diagnosed with a cancer and goes through that experience, but all kind of the people around that person who support them. So I think that kind of recognizes the caregivers, the family, the friends that become kind of intimately involved with what going through cancer can be like.
Yeah, I think that's right. And then, Stephen, when you meet with people, how do you talk to them about getting physically fit? What does it mean to be fit?
I think to be physically fit is just to be active. And, you know, any motion is good motion. Fitness can look like anything. It all depends where the person is starting from. So if somebody is just, you know, starting to move around again, just sit to stands from a chair might be a great activity. All in all, if we can find something that the individual likes doing, so that part of their fitness program is not doing something because they have to do it, but in part because they want to do it, and can cash in on that feeling of feeling better and energized afterwards. So fitness is as different as an individual would be.
I think that those are both great definitions to get us started. So, Dr. Choi, I know you do in your practice, obviously, given your title, you do a lot of survivorship care, primary care for cancer survivors. So, in the first visit that you have with a new patient or a new individual, what are some of the core components of a primary care survivorship visit?
I think that's a great question. I think it varies. I think it depends on at what sort of phase of the cancer continuum that we're seeing each other, meeting each other for the first time. So I think if it's soon after cancer diagnosis, I think that involves a lot of, well, what are the treatment options? What are you experiencing? What are you emotionally experiencing? Who have you met with from your cancer team already? So I think that's a very different conversation from, I've finished treatment, I've gone through a lot. Here are the kind of effects from treatment and cancer I'm going through,
Mm.
and I need to get over that. Versus, I feel okay. I feel like, you know, the cancer treatment stuff, I'm beyond that, but I don't know how to get physically fit anymore. I still feel weak. I still feel I don't know how to be eating. How does that impact my cancer? So I think a lot of what that first visit looks like, I don't have one set template. I think it really depends on at what point we're meeting. And sometimes we don't get into all the wellness stuff. And I think that's okay. Sometimes we just talk about, let's get a little more active, right? That's where we start, just like Stephen said. But I do like to, I think one thing that is helpful is to kind of set an agenda. I think sometimes, you know, we wish we could have all the time in the world for a visit. And usually that first visit, we do have more time. But I think being able to set an agenda for what we definitely want to cover. And some of that is what you as the patient may want covered. Some of it may be the doctor saying, I want to make sure I get this information so I know enough about you that I can treat you as well as I can. But setting that agenda up front can make the visit, I think, more productive so that we can move this.
Yeah, I think that's an interesting point. So, you know, I think one of the things that as oncologists, we often have agendas when we meet with patients, and then patients often have their own agendas, as you pointed out, to sort of like know what those distinctions are. And I always find that's the writing down the questions. Like write down your 3 questions or your 5 questions. You don't want to leave the visit without getting answered, right? So I know one of the things that goes into all of this is management of other medical issues, right? So oftentimes either during cancer treatments or after cancer treatments, things like diabetes and high blood pressure and high cholesterol are part of the picture. Is that something that as a primary care doctor who specializes in cancer survivorship, you find yourself managing or guiding patients to specialists? Is that part of cancer survivorship care, or is it separate?
Yes, I think as a primary care doctor, we own all of it. And I think that's part of figuring out what we cover in each visit. Because I think when there is diabetes and high blood pressure and high cholesterol or whatever that we're going through. We want to make sure we're managing those things. And sometimes they kind of take the forefront of a visit, right? If the diabetes is not under good control. Versus at other times, I may set aside a specific visit to say, let's not just talk about your diabetes, hypertension, but let's focus on some of the other things that we've put on the back burner the last 2 visits. And so sometimes it just does take more than one visit. And I think part of the job of the primary care doctor is to try to balance some of that. And some of that is obviously talking with the patient, with you at a visit, but it's our job to kind of, we call it kind of care coordination, but kind of keeping track of the different doctors and team members that may be involved, and also kind of keeping track of the other medical problems that we don't want to forget about.
Do you ever call somebody's oncologist?
I often will email or message them. I think we often end up playing phone tag. There's nothing wrong with talking on the phone. And I say, but there's a lot of phone tag that can happen. And so I have found that with my cancer colleagues at Hopkins, sending a quick message, I've done that with Dr. Weddington more than time. It's been wonderful. I think that's really key is communication that can go back and forth. And so, yes.
Now, Steve, when somebody comes to you for the first time, do they have to bring a note from Dr. Choi saying, yes, go ahead, cleared for exercise? Or I actually said earlier when we were talking right before we started, I try not to use that term exercise actually in this setting. I try to say, I like the phrase movement and muscle because really exercise is about, in many ways, moving your body and building muscle, aerobic and muscle. Anyway, so I'm going to try to stick to that tonight, actually, and not use exercise, but movement and muscle. When somebody comes to you to sort of initiate, do you say, hey, where's your note from Dr. Choi? Or how does that work? Do they need
in our program, people do come in with referral, and that's good so that there's a good continuum of care there. We want to know where they are in terms of their treatment, any concerns the doctor might have as far as degree of rigor or what they see as being appropriate. And I understand what you're saying about the exercise piece. I think a lot of us have had some less than successful experiences with exercise. And so just, establishing that movement, that activity is exercise. And it all depends, what your fitness level is currently as to what that may look like. So that's a big part of that, is to go ahead and communicate with the doctor, and then of course communicate with the individual just to see what their history has been with activity and what they like, what they're looking for. If we can come in and collaborate with that individual, oftentimes it's a whole lot more successful than if we sit down with them and prescribe, okay, this is what you're going to do. We certainly will give guidance, but we want to co-create this activity program together.
Yeah, that's going back to that care coordination, collaboration, all the C words, which are so important in all of this. Now, what about, we get questions a lot. Somebody will be on chemo and they'll say, what about my mammogram? What about my colonoscopy? And I admit, on active treatment, I always say later, like, it's okay. We don't need to worry about those now. So once sort of, well, when do you talk about sort of other cancer screenings? When are those important in the primary care process or plan for patients? And how do you advise patients about, like, let's say, for instance, they have a GYN cancer, but what about the colon and the breast, and how does that all fit together?
So I think some of it depends on when that first visit is with me, but I would say I often will reach out to the cancer doctor involved and say, how are we doing? Is this the time to pursue these things? I agree that in the midst of being treated and going through one cancer diagnosis is not the right time to be kind of shifting gears and doing screening procedures. I I think I have varied in the timing of when I reinitiate some of the other testing. Often I will do it within, the first few years after finishing treatment, but that first test can also be very hard to do, right? I think kind of going through a cancer diagnosis and treatment and then saying that we're going to go look for potentially another cancer is how it can feel to go through another test. And so I think once again, that is a conversation to be had. When is the right time for you? Here are the things that we could be checking for, and kind of maybe even introducing it before I think it really needs to be done. So I know that's kind of hedging a little bit, but I will say that there hasn't been one time where I'm like, you have to go get your mammogram right now. I think that's even for someone who hasn't had a prior cancer. I think it is a conversation to say, this is why I recommend it. This is why I think there could be benefit, but kind of hearing the patient out to say that it's a lot to say why maybe not they don't want to do it, I think can be very important.
That's a good way to approach it. I have patients ask often also about, well, if I've had one cancer, am I more likely to have another cancer?
Sometimes I think that's where it depends what that first cancer was and what the family history was and what some of those other cancers might be in the family. And maybe depending on what those answers are, if that individual may want to seek genetic counseling, and we have some wonderful genetic counselors here. And that can inform, do we need to be on a different plan for screening for other cancers because of the genetic component? So I think the question is maybe, and I think that's worth talking about with your cancer doctor or with your primary care doctor. I think it can go either way, but I think that's a great question.
Now, what about if people ask, so when somebody comes to you and they say, let's say they haven't had treatment at Hopkins, so you can't go on the computer and see all the records, and they say, I've had breast cancer and I got some chemo and I don't know what I got. The regimen they got is important in my understanding, because sometimes you also help screen for some of the long-term side effects of the treatments that they've had. Are there treatments that you are higher on your list that you think about more in depth in terms of potential long-term side effects, or are there ways in which you very directly look at this issue of long-term side effects?
Yes. So I think the type of treatment, I think most people can say, I have had surgery or I've had chemo or some sort of chemical or radiation. And I think depending on what is said can help prompt the degree of investigation we need to do. It is not infrequent that I will have to request records from wherever that patient was, that individual was 2 or 3 times, but I do find it to be important. um, yes, we know in general what standard of care tends to be. So what chemo is probably the most likely, but kind of finding out what the therapy was and how much can impact how we follow long term. So for example, the breast cancer example you provided, there are certain chemotherapies that long term can affect the heart. And knowing if you got that chemotherapy and how much of it could make me more in zone in on certain symptoms that an individual might bring up related to their heart. So I do think those things can be impactful even 5 or 10 years after completing treatment. So I do try pretty hard to figure out what that chemo or what that treatment was.
That makes sense. That makes a lot of sense. What about managing side effects that linger, like neuropathy, for instance, one of the most common side effects of cancer treatment?
So for neuropathy, I think we do have kind of the academic side, clinical trials that have shown us medications that tend to be more effective. I think it depends on where we are in the cancer course, and kind of how severe the symptoms are. So with a lot of chemotherapy regimens that cause neuropathy, we will say, let's give it a year. We typically say after chemo ends, let's give it a year and see kind of where it settles out. If it's super severe in that year, I will start medications to help manage that neuropathy or that kind of nerve pain, burning, tingling sensation, and continue the treatment thereafter. But really, in terms of like setting expectations, I say a year after finishing is when we would expect things to kind of be where they're going to be.
Yeah.
If they're causing a lot of issues in terms of being able to physically do things, I think that's where referring to someone like Steven to kind of help on the functional side can be incredibly helpful. So it really depends on, is it a pain issue? Is it a functioning issue because it's more numbness? Can also help sort out what the next step should be.
Yeah. And so, Steve, when people come to see you, you know, the neuropathy question also balance, right? So the numbness and balance issues can arise from the neuropathy. So if a patient was having neuropathy, would a physical therapy referral be an appropriate option for them? And then how do you help them, how do you assess and then help them figure out, you know, what options or what activities they can do to sort of improve that neuropathy function?
Yeah, it all depends to what degree the neuropathy is impairing them. We're community based, so we would be a supervised exercise program versus, say, a physical therapy. So, physical therapy might be appropriate at that time if pain management was a real issue. But even if they come to us with a degree of pain and balance issues, then there's a lot of things which can be done. Say, for example, offloading, putting them on bikes or on seated ellipticals or on any type of seated piece of equipment where they would get good cardiovascular, but wouldn't be getting all that workload through their legs. The treadmill may be appropriate as far as offering just enough challenge safely that they would be working on balance. Static exercise, such as standing at a bar, doing single leg activity, doing some strength training in one leg or two legs, just moving that weight out from the center of gravity. All these type of things can really facilitate improvements in balance, because as you get stronger, your balance reflexes also improve. So when it comes to, let's say, the pain aspect, well, offloading this individual may be good for the cardio. If their skin is intact and that's not an issue, water, aquatic exercise can be very beneficial. And there they get some of that touch cues, proprioceptive, kind of knowing where their body is in space a little easier. And just exercise generally. It just reinforces that communication between the brain and the body, the rest of the body. This is where I am. Here I am. Okay, I want you to move here. Oh, okay. Just, as we move, we're getting that re-education and getting to know our bodies again. Feeling comfortable in our bodies. Sometimes it's just that by necessity we're not able to do as much movement. Just getting moving again just can start that dialogue between the brain and the rest of the body.
Yeah. Speaking of the brain, Dr. Choi, I get a lot of questions about hair loss with chemotherapy treatments. And then is there anything to do that can make it better? Or could there be something else going on that doesn't make it grow back as thick as it was before? Do you get questions about hair also, or is that something that really gets directed towards primary care and towards oncology, and it ends up in the primary care office a little bit less?
No, we hear about it often. So, hair and nails.
Yes, nails. Oh, what a great, yes, nail.
Yeah,
Oh.
it's hard. So, one thing that I will check often is the thyroid function. I would say most of the time it's not the thyroid, but I think it's an easy enough thing to roll out with other lab work. So I do start there. They're not so much data driven, but some people really do feel like biotin over the counter can be helpful for hair and nails. So I do tell people they can give that a try, anywhere between a milligram, usually to 5 milligrams a day. But I tell people if they try it for, a couple months and it doesn't help, then, you don't have to spend the money doing it. But some people do find that it is helpful and it's safe. So that is that's usually my step 1 and step 2.
Yeah. Okay. Yeah, we get lots of those questions. Now, patients often ask about weight. So one of the primary cancers that as GYN oncologists we treat is endometrial cancer. And that cancer has been linked very much to weight and excess weight or obesity. And so when somebody comes into your office sort of newly through the treatment phase, now entering the surveillance phase, so they're not on active cancer treatment, how do you incorporate weight into the discussion, or what are some of the tidbits or thoughts that you start with when you're having conversations about weight and achieving or decreasing? It's always hard to say achieving a healthy weight is the goal.
Yeah.
It may not always be feasible. So how do you structure this issue for patients and help them figure out what their options are?
That's a great question. So I think the way I try to frame it is a little bit about, I do try to bring the cancer into it. Like you said, I think we've seen for not only endometrial cancer, but breast cancer, colorectal cancer, that there are cancer outcome benefits from achieving a healthier weight. And I start off by saying that to inform the conversation, because I think with cancer, oftentimes we feel so out of control, right, with cancer that it happened to me. There's not much that I feel like I can do about it. But I think in some ways, I tell them not to guilt people, but to say it can be very empowering to say there are things that I can do for my health that can have an impact on my cancer coming back. And I think that can be very powerful. And so I do kind of frame it in that way. I also bring in this whole idea of body mass index. I think it can be a challenging topic. So that's kind of BMI. So your weight adjusted for your height. And I say there are caveats around that, right? It does not take into consideration muscle mass. But the reason why I think BMI is helpful, or one piece of information, is that a lot of the trials that demonstrate that people do better with their cancer when their weight is better is based on BMI. And so that's kind of what we have. And so I say it's not everything, but that's where I find that to be helpful. So then I'll take someone's BMI, kind of where they are, and then kind of where a normal BMI would be, and say, well, maybe that doesn't make sense to go all the way down there, but what are the goals that we're aiming for, and kind of setting short-term goals and long-term goals. So that's the general framework I provide. And then sometimes we get into the nitty-gritty that first visit, or we kind of postpone that to another visit. And I'm happy to talk about some of the nitty-gritty, but that often involves folks like Stephen to think about a great program.
Yeah. Do people come into your office and say, I want to lose weight, and you help them set a goal? Or do most people really come in focusing on, I want to achieve that what is the new guideline, 150 minutes of aerobic exercise a week, I think is the latest guideline. So do you encounter this weight discussion on a regular basis, and sort of how do you have it?
Yeah, we certainly do. That's a question that we always try to manage, that the exercise is certainly a strong component in weight control, but it's the dietary factor is just so important. It's a whole lot easier to eat 200 calories than it is to burn 200 calories. So we like to address the weight part of it as part of the big picture. And actually with exercise, we kind of like to downplay that, because it is a slow progress, hopefully, 1 to 2 pounds a week. And I think many folks will come in with unrealistic expectations. There's a lot of misinformation out there. And the 150 minutes that you mentioned, time, duration of exercise, these type of things are really what's most important in the beginning. From our approach, we like to focus on longer rather than stronger. So, going into an activity, being able to sustain that activity for longer. So it will probably be at a level initially that is not going to be highly caloric burning. They'll burn calories, but that's not the real objective here. That's one of the nice byproducts. And, the weight can be challenging. And Dr. Choi was mentioning, doing things that we can control. I love the expression, we need to control the controllables. There's so much that's beyond our control. And one of the things that we can influence is how many minutes of exercise did I get today? How many minutes of exercise did I do last week? And just adding on to those minutes, 150 minutes of walking is wonderful. It doesn't have to be 150 minutes on a bike or jogging, just that type of thing. So we really try to steer people away from the weight and explain to them that, in the course of developing this healthy lifestyle, you will be having a positive influence on that weight.
Interesting. Now, you mentioned diet, and we get all sorts of questions about, should I have absolutely no sugar? Should I have alkaline waters only? Like, is there a particular diet, Dr. Choi, that's the ideal that patients should strive for? Does a no sugar diet make a difference?
So, my general approach for advising on a healthy diet, and then I think there is the diet to kind of lose weight. So I think those are kind of, they go together, but they're slightly different angles. The general diet I kind of go through with patients for healthy eating is this idea of a Mediterranean diet. And so there are guidelines for cancer survivors, and the diet guidelines within those kind of cancer survivorship in that kind of cancer survivorship framework really model that Mediterranean diet. So what we mean by that is healthy meats, and so really fish, then lean chicken are considered kind of the healthiest, and then there's kind of the other. So it doesn't mean you can never have a steak or a burger, but really kind of saying, where am I with that? If I'm doing red meat 3 times a week, maybe I can cut that down to once a week, for example. Doing grains that are whole grain options or complex kind of carbohydrates, so trying to cut out some of the white breads, the white rices, and focusing on more like whole wheat bread or brown rice. Lots of fruits and vegetables. So as much as that pyramid has changed, and it's not even a pyramid anymore, really kind of thinking about fruits and vegetables being the base of your diet. And thinking about fats not as your enemy, but picking the fats that are healthy. So fats that come from nuts, fats that may come from avocados and other kind of vegetables, can be really good sources of that are part of your diet. Alcohol is, it's not that it's not recommended, but I think general guidelines for cancer survivors say that no more than 1 alcoholic drink a day on average. And that is similar to guidelines for non-cancer survivors as well. I think in general, the guidelines as years have gone on have kind of cut down what the daily amount should be. In terms of that question about alkaline water and things like that, or no sugar, some people feel better when they cut out the sugar, but I usually don't say that it's no X, Y, or Z. I do find that being so strict, maybe for a time being, is doable, but I think we're trying to think of a diet that's for the long term. So you have to find a balance of what you think you're going to be able to eat for the next number of years, not just for the next month. I think there isn't really data on the alkaline water. I think if it somehow makes you feel better, I think it's okay. But I think from a data-driven perspective, we don't really know that provides any benefit. And then I think thinking through what is a diet that makes sense for losing weight. I think you can incorporate some of those principles of what's healthy eating, but Stephen is absolutely right that you don't lose weight by exercising. I think exercise or, moving, I love the term that you use, moving in muscle, that's really important to prevent further weight gain. I think it does provide that stability so that you don't gain weight. But in order to lose weight, we really do think that there needs to be kind of a change or a reduction in the number of calories that go in. And so there are apps out there, Lose It, MyFitnessPal, that can help you track what you're eating. I do think those apps are difficult to maintain forever. because they do take time to log what you eat and find how much you ate and all those sorts of things. But I think they can be very informative for showing you how much you're consuming. I don't think we realize sometimes how many calories we just took in with that bagel or that drink, that that glass of orange juice. And bagels are fine. I'm not saying bagels are bad or orange juice is bad, but you don't realize how much you're consuming in a day until you start tracking it. Or how much water we're not drinking that maybe we should be drinking. So sometimes those apps can be very helpful. And I do tell people, try to have plenty of water. Sometimes I think we do confuse thirst with hunger. And so making sure our thirst is quenched can go a long way towards not overeating. So
that was very helpful. I just sort of want to like listen to all that again, because I feel like you hit all the major sort of points and questions about all of that. Now, what about vitamins? Patients always ask, should I take vitamins? Should I take supplements? Are these going to help? And do they help maintain health? Do they help with weight loss? Do they help, do you see benefit in adding a vitamin regimen for cancer survivors?
I think it depends on the situation we're in. I think there are certain cancer survivors who may be, because of their surgery or treatment, more predisposed to being low on certain vitamins. I would say in general, I don't say everybody has to be on a vitamin. I think ones that I tend to have my patients on would be, one is vitamin D. I check a vitamin D level in many of my patients at least once. And that helps me determine if, they're deficient in vitamin D and we should supplement. A lot of us, I think, are vitamin D deficient. It's a process where the sun hits our skin, there's a chemical reaction, and our body makes our own vitamin D, but we're not outside as much. We put on appropriately sunscreen and everything else. And so that really may affect how much vitamin D we make for our bodies. Vitamin D is important because it's helps us absorb calcium, which is important for our bones and our bone health. And so that's how those things kind of tie in together. So vitamin D ends up being one thing that I do have people supplement. And then the calcium I mentioned for bone health as well. Calcium we can get through our diet. Dairy is a big source, soy, dairy-like products, so soy milk, almond milk, and some green leafy vegetables. But sometimes it's hard to get 1,000 to 1,200 milligrams a day. And the guidelines vary in terms of exactly how much, depending on, for a woman, if you're postmenopausal or premenopausal, or if you have bone health issues. And so that's a lot. It's typically 3 to 4 servings of dairy, and most of us aren't accustomed to doing that much. And so often it becomes this balance of figuring out how much you do in your diet and getting the rest through a supplement. And I think calcium pills used to be big white horse pills. They're not anymore. You can get gummies, you can get caramel, chocolate chews. There's different ways to get your calcium. And so I do think those two supplements I do have a conversation with patients about. And then I think the rest, it depends a little. In general, I don't think we need to overdo vitamins. Some people feel better on certain supplements. So the agreement that I come to with a lot of individuals is just to say, if you're going to start something, please let me know what it is so that I can look it up and make sure it doesn't interact with your other medications, that it doesn't do something funny with your liver or your kidneys. And so there's only one way to know. I need to check and make sure it doesn't have that. And then the last thing I'll say about that is there is a caveat with supplements. They're not regulated the same way that drugs are. And so there is a little bit of, you might not know what you're getting. There may be the ingredients that are on the bottle, but there isn't the same sort of regulation to guarantee that that's what you're getting. And so I do tell patients that I don't think that's as much an issue with like calcium and vitamin D, but there are maybe some more esoteric supplements where that might be the case.
Yeah. No, I think that's often a neglected element, that all the things that are in the pharmacy on the vitamin aisle are not actually FDA evaluated to know what's in them. So I think that's always a very good point. I think you also said something else that's always super important that I try to remind people is tell us what you're taking. So if you're on vitamins or supplements, or you're getting something from a family member, tell us, because there are some good resources to be able to look up online and make sure that it's not interacting with, I mean, I think about it in terms of their chemo, but you probably think about it as, is it interacting with their blood pressure medicine or their diabetes medicine or some other medicine? And sometimes these things have interactions you wouldn't think they have. So I think that's always super important. Steve, if you were to give, some of our patients certainly can't, due to balance issues or just due to mobility or things that have happened, kind of can't get up out of a chair to do a walk like you mentioned, or to even go to the gym. Are there exercises that are available to people who are confined to a chair, be it a wheelchair or just really very limited mobility? Or do you really have to be able to get up and walk in order to get yourself on this path?
No, absolutely not. Sitting in a chair, kicking one leg up at a time, that's working your thigh muscle quite well. And marching in a chair is certainly good. If somebody has a hard time getting up out of a chair, well, maybe they put a cushion down and they get up from that higher level and then gradually start to decrease the height of their chair. It's a wonderful way to go ahead and strengthen the leg and get up. If somebody's confined to a wheelchair, then doing the partial raise from a wheelchair using their hands and their legs. So I think at that point they probably would be being seen by physical therapy. There's a whole host of exercises that can be done. If somebody can't sit up and is laying in a bed, there's a whole host of exercises that can be done just laying flat on your back in the bed. So as you said earlier, muscle in motion, it's so true. Yeah. Just about any fitness level, deep breathing can be a chore at certain stages of health. So yeah, there's always challenges that we can provide and give to ourselves at all kinds of different levels of function that help. I mean, the whole premise, and I'll use that E word of exercise, is it's almost a Darwinian thing where you're just putting a force on your body, on that biological entity that's a little bit beyond what it can comfortably do. So it's having to make some adjustments so that it can do it. So it all depends. You can come from any level of function. And if you're adding something that's just a little harder to do, that's productive.
Yeah. I think you hit so many good points there, which is with proper supervision, everybody is able to increase their movement and their muscle. And maybe for some, it does require specialized, guidance of somebody who's specially trained, like a physical therapist, and for some not. But I think that you brought out what I was hoping would come out, which is that for every individual, there is the possibility of making incremental changes. And so that, whether it's deep breathing or exercises in bed or exercises in a chair, there is possibility for everybody to
be able there's just so many things you can do at home. Say that you don't have access to an exercise bike or the capability. If you have a tile floor and 2 dishcloths, you're sitting in the chair, you put your feet on those dishcloths and just start running your feet forward and backwards. I mean, it doesn't have to be complicated. It doesn't have to be sophisticated. There's a lot that you can do.
That's excellent. Now, one of the things we've talked a lot about body, and certainly those are all issues. What's the, if you could talk briefly about what do you see as the impact on things that we often think of as kind of here up, but yet are about our exercise. So things like feeling fatigued and feeling anxious and depressed, or in distress, or upset in as you different for cancer survivors, different phases, disease adjustment, finishing therapy, and adjusting to being in a survivorship mode. How do you Steve, in your practice, how do you see patients experience these transitions as they begin to exercise? And then Dr. Choi, when patients come into your office and sort of bring these issues up, what are some of the strategies that you recommend folks employ? Clearly, I'm a big mind-body person, given the way I phrased that question, or was intended it to be phrased. Who wants to go first?
Is that that is, I think, in my opinion, it's one of the biggest benefits of movement is just the endorphin release, the stress management aspect of it. Cancer survivors have a lot on their plate. It's nice to be able to get away from all of that, to get moving, to get that sense of empowerment. Energy begets energy. It's really hard in the beginning oftentimes to get moving. But one of the things that people appreciate early in a movement program is that energy. The energy comes back. They feel the reservoir really does grow. They're usually their stress levels will decrease. Their mood becomes more elevated. That's the thing that tends to hook people. It's not the strength gains or the cardiovascular gains initially. It's how they feel afterwards. And I think a lot of times in our, somebody who's going through a lot of medical procedures or processes, they are having things done to them or things given to them with activity. That's something that they're doing. They're bringing to the table. So it's really empowering. And I think it is so productive from a mood standpoint and from an energy standpoint. And as somebody who works with getting people moving, that is probably one of the biggest factors in, we use that word, exercise. Oh, they just feel so much better, and they come back. They see that result. They see that result early in the game.
Yeah.
I'm glad you went first because you said all the right things at the thing that I bring up with my patients. So I'm done. I guess the way I frame it for my patients, so I think fatigue is common, low mood is common, stress, especially with this pandemic, is out the roof for so many of us. And as I've seen patients for their annual visits or their follow-up visits, we end up talking about all the stress. And they know that I'm going to bring up the diet and exercise, but really I tell them, I do remind them these are the guidelines, for heart health. But I was like, me telling you that it's going to keep your heart healthy in 20 to 30 years isn't going to be what motivates you. Like, what's going to motivate you is remember when you were exercising and you felt better, right? That's what motivates people to kind of go back to it. And so I think when people are going through a lot, yes, we want to make sure we're ruling out things from a medical standpoint for fatigue. There are a lot of things like anemia, thyroid issues, et cetera, that it's my job to take a look at. But I think beyond that, it's also making sure we have good mental health colleagues who are involved, whether that be a therapist or psychiatrist, if that's helpful. And the exercise or the moving, the physical activity becomes so important. And part of that is also, the last few days have been a little bit more challenging with the snow, but getting outside, I think the value of getting outside even every day has been helpful for so many people. And so I do try to encourage that, whether it's in the context of a walk or just to get outside. And often you can kind of accomplish the moving bit and the getting outside bit at the same time.
At the same time. Yeah. You mentioned getting outside and you mentioned the pandemic. And so I'm going to ask a question that's not going to be of enduring value. Hopefully we aren't going to be doing this for too much longer. But Steve, are gyms open? Can people go to a gym right now or to a physical therapist? And so, or is that still limited?
Yeah, no, gyms are open.
They are, okay.
All right. Yeah, gyms are now in Maryland. They reopened. It was June the 19th, and so they've reopened with distancing enforced. A lot of the facilities have air treatment ionizations, which go ahead and because this is a respiratory and airborne type of issue, virus that we're dealing with, to treat it that way. There's a lot of cleaning protocols that are in place now at the gym. At our facility, we use a hospital grade disinfectant that we're cleaning the equipment during the course of the day, and the people who work out cleaning before and after. You know, it's a complicated question, because if somebody's immunity is compromised, then if they are to go to a gym, they really should check out what their protocols are and go during periods of time when they're not as busy. So I think that there's certainly some steps that have to be taken by individuals if they decide to go that route. But I would say, because intuitively people think, oh, a gym, do I really want to be going to a gym during this period of time? As an industry, we've had to make so many accommodations and put protocols in place that we're probably safer than grocery stores, just because of points of contact and touching and flow control, people control, if you will. So those responsible gyms are certainly safe and viable. But again, for the patient who might be compromised, well, that's a good discussion between them and their doctor, and to also, you know, look at the protocols in place at that specific facility.
I do want to go back to the exercise and fatigue, and we didn't touch on sleep actually. And so we're on Facebook Live while we're also doing this platform, and so somebody asked about exercise and sleep, and then just sleep in general. So does exercising at night make you not be able to fall asleep?
It all depends on the individual there. Yeah, for some people it'll wrap them up, and it's hard for them to go to sleep. Other people, it knocks down that stress level and they're relaxed afterwards. So it's just like every exercise or movement program has to be individualized. That, I think, is another piece. You know, one man's ceiling's another man's floor. It all depends.
Yeah. And then how do we help people sleep, Dr. Choi?
That is a complex question. So I think, so yes, sleep becomes one of those things that I do like to bring up with my patients, because I think it impacts fatigue. It impacts kind of what the day-to-day is, and how I think stress levels, right? When I don't get a good night's sleep, I don't feel great the next day, right? And so I think it does kind of help give a fuller picture of what's going on with the individual. I think sleep, you know, disruptive sleep can come from so many different things. And so I think kind of going through what might be impacting that can be helpful. So some of the things that I always like to cover with when we're talking about sleep is, what's your caffeine intake, right? And so not just the obvious coffee, but the decaf stuff, the teas, when do you cut it out? And so I think the caffeine, even though you may have been doing 2 cups of coffee for the entire life, if you can't handle it, if you're not sleeping well, then we need to kind of revisit that, for example. Alcohol, the same thing. It's, you know, we mentioned it a little bit earlier. It's not that you can't have your one glass of red wine at dinner, but if you're telling me you're sleeping poorly, you know, we know that alcohol can cause less deep sleep or restful sleep. And so then that's one thing we need to think about. Late night eating, maybe it's obvious acid reflux. Sometimes it's not that, but that can still, we think heavier late meals can impact how we sleep. And then I think what the bedtime routine looks like. And so, you know, if we're going to bed at midnight one day and 10 o'clock, there is this idea with, I think, with sleep specialists that I've communicated with, it, having a bedtime routine, having a kind of general bedtime can be very helpful. Or, you know, we do that with our children, right? Like, you know, my husband's doing that with our kids right now, is having a routine, bedtime, the book is so helpful for children. Why do we think we don't need that anymore? And so the routine can be helpful. And then, you know, I think sometimes when we're lying in bed is when we start stressing about things, all those things that we need to do the next day. And the weight of the world, you know, is on our shoulders when we're trying to fall asleep. And so there is this idea that if your mind is racing and you're not able to fall asleep in 10 minutes, don't just keep staring at the clock and lying in bed. Get up, go read something, not on your phone or a screen, but, you know, something that you've already read for, something boring. And then after 10 minutes, try going back to bed. And that tends to help more than just lying there for 30 minutes. And then screens. In general, the thought is that screens, even if you do kind of the nighttime black, the black background screens, it still stimulates our brains. And so trying to shut off the screen 30 minutes, ideally an hour before bedtime, can be really helpful. So those are some things I go over. I think there's more that can go into it, but we try to hit the basics and then see where we get to at the next visit. And then melatonin sometimes can help. I'll just throw that in there.
Yeah. We're getting close to the end. I always run out of time before I want to run out of time. Most of the people who listen to our webinars are Hopkins affiliated, not surprisingly because of our affiliation, but there are actually many who end up joining who are family members or friends or here from all over the country. So I have found that finding a primary care doctor who specializes in cancer survivorship it's unique. Your niche is a unique niche. So do you have any words of wisdom for somebody who's not local here in Baltimore, who can't look you up tomorrow morning or tonight and call and make an appointment with you or one of your partners? Is there a way to find a primary care who specializes in cancer survivorship if a patient wanted to do so?
So I will say that this kind of movement to have primary care doctors have some expertise in cancer survivorship is growing. So if it's not near you yet, hopefully it will be coming soon. And so I do think there is a lot of interest among internists to have this be their niche. So I will put that out there. I think two other thoughts around that. One is whoever your oncologist cancer team is, they may have primary care doctors that they have experience with that, maybe they don't advertise themselves with the title that I do, but like that they see a lot of cancer survivors. I think a lot of us internists do. We are the ones that send out, order the mammograms and the colonoscopy. So we often have some expertise in managing. And so I would ask your cancer team, is there a primary care doctor that you would recommend, for me? So I think there's a lot of value there. And then thirdly, I think there is this general sense in the primary care community that with good communication from the cancer team, we feel a lot more equipped to handle the effects of cancer treatment, to know what to do in terms of helping coordinate the tests that need to be done after cancer treatment is over. Sometimes it's a formal document that we call a survivorship care plan, but it doesn't have to be that. I think a letter, some kind of summary note from the cancer team to the primary care doctor can keep that primary care doctor informed and kind of open up that line of communication. So I don't think every primary care doctor has to say that they are in this specialized program to be the right doctor for you. I do think that the benefit of being in primary care is that we are used to wearing a lot of hats and communicating with a lot of other colleagues. And so my hope would be that, even if your primary care doctor has never said, gosh, I'm here to just manage your cancer, because maybe that hasn't been something they've had to have that conversation with you about before. I would bring it up with them and say, what do we do now? What's your experience? Can you talk with my cancer doctor? And I think there's a lot that can be accomplished that way.
I love it. That's great. I sort of had ending questions. That was my ending question for you, Dr. Choi. And Steve, I was wondering if you've shared with us throughout the evening some of what I think are your favorite exercises or activities, movements. You mentioned the walking, you mentioned the chair and your feet, you mentioned the deep breathing. If you had to pick one movement that you shared with people and they were only allowed to do one, which would it be?
Well, I tend to be functional oriented, so something that looks like walking. I
thought you might say it. Yeah, you said that earlier, and I was like, I think he just stole my closing question the way he talked about walking. Thank you guys so much. These are great informative sessions for patients, and we continually get wonderful feedback. And tonight has been very interesting and great. And you guys both sort of touched on such important issues for patients and gave a good blueprint. And I think key take-home messages were conveyed, including the very basics that we always have to repeat, which is check with your own doctor, figure out what your own doctor feels is safe for you. So don't go out and do anything before talking to your doctors. But other than that, beginning to think about your own wellness, developing your questions that you take to your primary care doctor's office. Hopefully we've given you some today, and then figuring out how to incorporate into your plan, movement, exercise, muscle, however you want to phrase it, and developing a wellness plan that hits your enjoyment so that it's sustainable because it's something that you enjoy, be it the foods that you choose, the exercise that you choose. Think about the short term and the long term, and come up with something that works for you. And hopefully tonight we've passed on enough options that something will suit you and you'll be able to pick it up and run with it. So thank you everybody for joining us tonight. Thank you, Dr. Choi. Thank you, Steve. It has been a pleasure. You've both participated in our conferences before, and so that's why we knew you'd be great people to have with us tonight. And we really do appreciate your time and all your wisdom. So thank you.
Thank you.
Thank you for having us.
Absolutely. Thanks.